pictures, trying to get mostly us as speakers in here, so not necessarily that you guys will be in that. And then Stephen was milling around. He is a physical therapist as well, with 10 plus years experience. And if you need anything, questions at the end, he can answer, I can answer, Chad can answer too. And we'll take questions throughout the presentation too. So feel free to put your hand up if we say something and you want to ask more in the moment. We like that. And we'll be doing a little bit of a test of your balance today, and we will need a volunteer at some point. So you won't be just sitting there for a lecture. So hopefully it'll be a entertaining evening for tonight. So I'm going to pass it off to Chad.
All right. Well, thank you guys for coming. I guess just by a quick show of hands, just to give me an idea in terms of what your guys' primary interests are. I know this is kind of a balance and then neuropathy clinic. So I guess if you're interested in the balance part of it, if you would raise your hand. Okay, and then how about for peripheral neuropathy? You can vote more than once. Okay, so actually a fair amount for both, which is good. So I'm going to talk primarily about balance, and then Jennifer will talk about peripheral neuropathy part of it. Part of peripheral neuropathy ties into balance, so I'm going to kind of get a little bit of an overview as I'm talking too. So, okay, so what is balance? So if you were to ask me, I would say that it's your ability to keep your center of mass over your base of support. Yes?
Can we ask you to speak up just a little bit?
Yeah, let me turn this up.
Yeah. I'm like, do you want me to get that, Chad?
Okay.
He's getting so good at that scooter, you guys.
Yeah, by the way, sorry, I broke my foot last week, so I get to be a little hobble around here, but I'm making do. Okay, so if in terms of kind of from a PT's perspective, it's basically our ability to, is that better, sound-wise? No? Yes? That part, unfortunately, we tried, and that's as far as it'll go. So I'm going to try to explain most of all of it that it says on there. So, okay. So in terms of balance, what is it? It's our ability to keep our center of mass over our base of support. In terms of what does that mean to you guys? It's your ability to stay upright, so minimize the risk of falling. So I put some facts on here just to kind of show what the rate of falls are. So I guess if you guys are brave enough, would anybody, within the last year, has anybody fallen in here? Okay, so you are part of these statistics. So 1 in 4 adults fall each year. So 25% of people, that's a lot. So it results in 3 million annual visits to the ER. It results in over $50 billion in annual medical costs. And about 95% of people that fracture their hip, it's the result of having a fall. But beyond just those statistics, the psychological toll that falls can have on people can be significant. So a lot of times when people fall, they become fear avoidant of activities. They don't want to do those things anymore because it results in them falling. And then it kind of takes away the things that people enjoy doing. So the goal with balance training is to restore your ability to do the things that you enjoy in life. So in terms of how does our body maintain our balance? So our brain basically acts as a giant computer, and it gets input from multiple systems in our body. And I'm going to kind of talk about each of these systems a little bit differently, but what they are. There's vision, there's somatosensation, and then there's vestibular input from the vestibular system in our inner ear. In terms of what our brain does with all of these things is it processes information from all 3 of these systems, and that helps keep us upright. So the very first one is vision. Vision represents about 70% of our balance. So where this becomes problematic is that people, if you have visual challenges, or all of us are affected if it's dark outside. So if it's dark outside, we're walking around, we can't use our vision very well for balance. So that's a lot of times when people are getting up from bed at night, if you don't have any lights on, you're making your way to the bathroom, people oftentimes will end up falling from those. So one easy solution to that is to use like motion activated night lights, those types of things, to try to minimize the risk of falling because you don't have visual input. Another one on here would be cataracts, glaucoma, can also have some significant impacts. So the next thing we use is somatosensation. So somatosensation is basically our body's ability to know where we are in space. So for example, if I have my arm back here, I cannot see my arm, but I know exactly where it is. So the way that we do that is we have stretch sensors in our muscles, tendons, and ligaments that tell our brain where our body is in space. From a balance perspective, where this becomes important is what we get sensation-wise from our feet. So this is going to tie into what Jennifer's going to talk about with peripheral neuropathy. but we use the sensation from our feet to know where our weight is distributed. So if I start to lean forward, I'm going to feel more weight on my toes. If I start to lean backwards, more weight on my heel. My body uses that to try to keep me centered. With peripheral neuropathy, when people lack that sensation input, you're not getting that input. So again, that's another thing that would place people at an increased fall for risks, or risk for falls. So the last system is the vestibular system. So this is the one that I spend a lot of time working on with people. Our vestibular system is basically, we have one inside of each of our inner ears, and it acts as our body's built-in gyroscope. If I were to turn my head, let's say 30 degrees to the left, the vestibular system is what is going to tell my brain that it did that. So in terms of kind of how does it do that, it senses the direction that we've moved and also the velocity, the speed of our movement. At the end of the day, what it actually controls is our eye tracking. So if I'm looking at somebody and I turn my head, I don't have to think, oh, I turned my head, I need to move my eyes. It's a reflex. And so when the vestibular system is not functioning correctly, that reflex is off and our eye tracking is off, and it actually affects our balance from that regard. So some of the common vestibular disorders that I treat, so one is BPPV, which stands for benign paroxysmal positional vertigo. And this is where people, if you've ever heard somebody say they have crystals in their inner ears, this is what they're referring to. So we have another portion of our vestibular system that tells our brain where gravity is. So the way that it does that is you have little calcium crystals that are attached to hair cells. When we move our body or head in a certain position, gravity pulls on that crystal, hair cell bends, and the brain says, okay, that's where down is. For whatever reason, sometimes those can break off and they get displaced into a different part of our vestibular system, and that's what triggers positional vertigo. So this is the people that if they lay down in bed, roll over to their side, and they say, I feel like I'm on a merry-go-round ride, this is what they're having, most likely. Okay? So another one that I see a fair amount is vestibular neuritis. So this isn't going to be the merry-go-round sensation. This is going to be more somebody that turns their head or body real quick, and they say, whoa, and that lasts for a few seconds. At that point, what oftentimes happens, because we have one of those systems in each of our inner ears, is if something happens, oftentimes it's viral related, where it affects one side, you turn. One side says you turn 30 degrees, the other side you said turn 20, and because it controls our eyes, our brain says, those are two different things, I don't know where I'm supposed to be. So a lot of times people will experience that brief period of off balance until kind of the brain stabilizes using those other systems. So, and then I put a kind of an interesting fact on here, just that vestibular dysfunction affects upwards of 35% of adults over the age of 40. So again, a pretty fair amount. Okay, so this slide, so in terms of, now we know where all that information comes from, what does our brain do with it? So we use 3 different strategies in terms of our balance. So the very first thing we do, and you guys are actually going to feel this in a little bit when we do one of our little tests, is we use what's called an ankle strategy. So if I was to start to lean forward, what my body's going to first try to do to keep me upright is it's going to push off on my toes. It's going to try to push me back so that I center back over my feet. Now, what you have to have in order for that to work is you have to have adequate leg strength. So that's something we're looking at when we see somebody for balance, is we're looking to see, do you have adequate leg strength? Is that one of the challenges? The next thing is if we can't push off sufficiently with our ankles, the next thing we're going to use is what's called the hip strategy. So if my body tries to push off on my foot, doesn't work, the next thing I'm going to do is try to move from my hips. Okay? Again, there can be a strength component to that, but a lot of times if people, let's say you're doing a balance activity and you go, oh my gosh, I'm all over the place, that's not necessarily a bad thing. It's just that your body's using a different strategy. I always tell people our main goal here is to stay upright when working on balance, not to stand perfectly still. Okay? So, and then the last thing we should use is what is called the stepping strategy. So if I couldn't correct it with my ankles, I can't correct it with my hips, my body, without me even being aware of it, should take a step in the direction it thinks that I'm going to fall. So that's often if somebody's about to stumble and you feel like, oh, I'm kind of taking that step, that's actually what that is. So when we're training balance, we want to strengthen these 3 systems, because a lot of times what I'll find is people are like, oh yeah, I'm working on my balance. And I say, okay, what do you do? And they say, I'm standing at my counter, I'm standing on one leg, and I'm doing this. And they're catching their counter when they start to lose their balance. What you're actually doing is training your body to reach and grab. So if there's nothing there, that's when it becomes a problem. So typically in terms of vestibular rehab, we're working on balance, we're trying to strengthen that ankle hip stepping strategy, to basically allow your body to use those things rather than relying on external structures. Okay, so and then in terms of kind of dizziness, so again, I highlighted a few of these things. So vertigo, that's again where the crystals loosen that inner ear. You roll over, that gravity makes the crystal move. That's our merry-go-round sensation. Okay. Lightheadedness is a different cause. Oftentimes this can be caused by orthostatic hypotension. So this is somebody that they're in bed, they get up quick and they go, ooh, I feel lightheaded. Lasts for a few seconds, kind of settles and says, okay, now I'm ready to go around. So again, there's a lot of things that can affect that. People are on too much blood pressure medication, if you're dehydrated, those types of things. So again, a lot of this is patient education. If you guys are coming in, we're trying to troubleshoot these things, say, why are you getting lightheaded? That is not a normal response. To try to fix that as well. So disequilibrium, it's not, these are some kind of confusing terms because you say dizzy, disequilibrium, all of these things. So disequilibrium is going to be a sensation like you feel like you're on a boat. So again, this can come with, if you turn quick, you kind of have that unsteady type of thing. So that's what disequilibrium is. And then we also see non-specific dizziness. And Jennifer is going to touch a little bit on this at the very end, but a lot of times these people are people that come in and they say, I feel foggy-headed. So not necessarily dizzy, not necessarily on a boat, but I just feel my mind is not quite clear. So there are some things we can do for that too. Okay, so this is where it gets a little bit more interactive. So I'm going to have, if you feel comfortable, I'm going to have everybody stand up for a second. Okay, and if you feel comfortable, I'm going to have you actually move your feet all the way together so that they're touching. So, and even just the pure fact of doing that, you're actually going to feel a little more off balance. So the more narrow our feet are, the smaller our base of support. Now, if you have a chair in front of you, kind of hover your hands above that, because what I'm going to actually have you do for a moment, and please, if you feel like you're going to topple over, open your eyes, but I'm going to have everybody close their eyes for a second. Okay, good, no one fell over, thankfully. Okay, but did you guys all feel what happens when you do that? You feel more of that sway. So what's happened is you've taken your vision away. So now that 70% that we rely on for our balance is gone. So the brain basically says, okay, I can't use that. Now I have to use my vestibular system, or I have to use what I feel from my feet, proprioceptive input. Now, if someone wants to volunteer, everybody can sit down. I don't have enough foam pads unfortunately, for everybody to do this. If at the end you want to see what your balance does, you are welcome to come find me and we can practice. But if somebody wants to volunteer and come up here, Chuck, you want to do it?
Go ahead.
I'm going to have Jennifer stand next to you because, just in case, you don't want the guy on the knee scooter to try to catch you.
And I'll grab the
yeah, it is that foam. So what we're going to do is we're going to have her stand on a piece of foam. So the foam, obviously you're going to say, well, when do I ever stand on foam? And the answer is you probably don't. But there are softer surfaces. So the difference between walking, let's say on concrete, something very firm, or you walk on grass. So grass is going to be an example of what you would feel where you have diminished sensation from your feet, or decreased in terms of body awareness. So I'm going to have you still stand with your feet close together.
There you go.
Okay, you're doing pretty well. So now I'm going to have you look straight ahead, and then Jennifer will not let you fall. Okay, and then I want you to close your eyes. Okay, you may open. Okay, was that a fair amount more sway than you had with just the on solid ground? Okay. Yes. So, and at that point, what we've done is we've decreased sensation from our feet. So you're not getting that proprioceptive input. We've taken away your vision. And really the only thing that you really have left to use is your vestibular system. Okay, so as we take more and more things away, it becomes more and more unstable. So thank you. Thank you. She didn't let you fall.
Yes.
So, but those are very basic tests that we'll do when people come in just to kind of see where you're at. It gives me some understanding of what I need to do in terms of working with you. So is it something we need to work on standing on uneven surfaces? Is it something we need to work when we take vision away? Because there are going to be circumstances in day-to-day life where we don't have those things. So an example is people say, well, I don't close my eyes, so I don't have to worry about that. But you're in the shower and you're shampooing your hair, and I guess most of you probably close your eyes. And a lot of people get a little more unsteady when they do that, especially when the ground's wet. So there's some carryover in real life situations. So the other part that we want to kind of go over is we have a device, it's called Upright VR, and it uses virtual reality to actually objectify your balance. So when you were standing on that piece of foam and you close your eyes, I can say, yes, you had more sway. Okay, or I could say, if we did have to catch you, you stood there for 5 seconds before I had to catch you. So there's a lot of subjective nature to it, basically, on what I'm saying, what your balance looks like. So let's say I could say, okay, we're gonna work on your balance for 6 weeks, and you come back and I say, okay, do it again. And you had a little bit of sway and you balance for 10 seconds that time. It's like, well, you got better, right? So the upright VR is gonna be a little more specific. It's actually gonna give you a score. It measures sway in all the planes. And it's gonna be an age match norm. So it's not like we're expecting everybody to balance the same way. It's basically gonna look at what your age is, what most people's balance is at that age, and it kind of gives you a percentage of where you're at. It also helps us identify where your impairment is. So it's gonna do some different things visually. That's gonna say, is it from your vision that's the problem? Is it from your vestibular system? Or may it be from actually what you're feeling or lack of sensation from your feet? So this one takes a little bit longer, but you're gonna each kind of be able to see what the test looks like. It'll in here, so somebody gets to volunteer again, but we're basically gonna put this on your head, and then we're gonna put on the screen what they're seeing, so you'll be able to kind of identify, okay? All right, does anybody wanna volunteer for this one? Okay, come on up. Okay, do you wanna put in her stuff real quick and so we'll just have to do, it just really needs height, weight, date of birth. You can just make up a.
Okay, hang on. 5, 6,
135.
I get it to go to the month. I got in the year. Oh, I see here. So okay. Doesn't like.
I know,
I
it'd
got
be
it.
nice if it just let you type it in.
And I'm like, you said January.
My birthday?
Yeah.
August.
Oh, it's
17th.
August 17th.
Happy early birthday.
He's 70.
Oh, nice.
Okay, at height, weight, and then do you want me to put your name in here?
Different. DEBORA.
Last name?
ZACH.
Oops. CHA. Okay, and then just hit select assessment.
Sure. Just click on the headset. Sure, it should be good. Okay.
Yep.
So go ahead and do select assessment.
Okay.
And then we're going to do the bottom one. Or on the far left.
This one. And then this says something. Please ensure the headset you wish to use connected to the internet and currently running. No,
Please ensure.
Yeah.
Headline.
Yeah, he's checking that.
All right.
Okay. Go ahead and
Select it anyway.
Yeah.
And hit begin.
Yeah. That's it.
Yeah, technology is always awesome.
See, when you're old, you get cataract surgery, and then you can see.
Okay. Yeah. Do it again. Go back up here. Click on the headset. Just click on that.
Yep.
Okay. Now go ahead and do begin assessment. Okay. Have you had any falls in the last?
Not
Recently.
recently.
Okay.
Way
Have
past
you ever
this.
worn a pair of?
Yes, my daughter.
So
Okay.
Made
Yep.
sure.
So we'll just do that.
I
no.
knew how to play with hers.
All right. Awesome.
Okay.
Okay.
Okay. So
You're
I'm gonna
gonna
have
come over
you.
here?
Yep.
Which
We're
one
gonna.
do you want me to say?
We're gonna face that way.
Do you want her shoes on or not?
Let's leave them on.
Okay.
Okay. Actually, if you want to kind of help put that on.
Yep.
This way. I only have one hand.
One hand or one foot. my
I know,
goodness.
right? Oh, come down just a little bit with that.
Oh, I'm gonna move your hair clip a little
That's
bit. Okay. Is that better?
Let's go. I've got it. Okay.
All right.
Now go ahead and
Now tighten it.
Yep. Okay. We're gonna have to take your hair clip.
I don't.
think
I think it's the hair clip.
Yeah.
I'm sorry.
That's all right. Just
I'm like trying to be too nice. I'm like, that's just not gonna work. Okay.
it's fine. I'll
Okay.
clip it later.
Yeah. Go ahead and push it down a little bit more. There we
More.
go. There we go. Perfect. Okay. Now go ahead and tighten. Okay. Does that feel okay on your head? Okay, so see, when you get this done, you gotta wear this cool thing. So I'm gonna have you, let's have her step to the left just a little because she's covering up the.
Come to the left.
You're gonna come.
Yep, you're gonna come to the left. There you go.
So I know it's very small from what you guys can see, but there is on the screen kind of a picture. So what it actually looks like when she's looking into there, it almost looks like you're in a spaceship. So I'm gonna have you go ahead and before we do anything, go ahead and look around, just move your head.
To the left, to the right.
Yep.
Yep.
Then you're gonna just kind of see more of that spaceship design. So we're gonna do, there's 4 different conditions. So each one's gonna progressively get a little bit more challenging, but the very first one we're gonna do is just gonna look at our baseline balance, okay? And it's gonna kind of walk you through, you're gonna hear instructions on your end. So, and I know you guys can't hear it, but no. So it kind of gives you a little bit of rundown. We'll also go through what you're supposed to do. It's just explaining what she's gonna do so she understands the test. These only take 20 seconds, so it won't be.
It'll go quick.
Yeah.
Once it's done.
It's just the setup part's hard. Okay.
Yeah, it's done.
Yep. We're gonna go ahead and just do. Do it again.
Went past that one already. Did it disconnect
I
it?
don't know. Looks like it is. You still see the same thing?
No,
What does it look like?
I'm looking at all screencast settings, UVR recover, manage, file manager. So
Oh, wow.
there's a selection
Yeah.
of boxes. Like,
Oh, whoop, you're good. You're fine. I'm standing
There's
right next to you.
Even if you get mad at us, then you can hit us.
Library.
All right, I'm gonna borrow your headset. So I'm gonna
Give
take
us
it
a
out.
I know
moment.
you're over there because of the voice.
I am, yes. All right, sorry.
Somehow it got disconnected. It shouldn't have, but always fun when this doesn't cooperate. It was paired.
Yeah.
Are we gonna have to go back out?
Yeah, I think we should be back. Okay, so go ahead and make sure, click on that thing again, see if it's.
Okay, now it's
we're good,
green.
We're good. Okay.
Okay.
Let's put it back on real quick.
Okay.
All right, we're back in business.
Slight delay. There you go. And
All right, you still see the
Now I'm
rig-
looking at,
spaceship again?
the spaceship is open
Okay, I recentered for you.
and the Earth is down there.
there you go.
And we may have to back out of this and go.
All right.
All right. I'm just gonna skip forward past the instructions.
Now, are they looking at the spaceship?
They can see the screen that
yep.
you see. It's small on the screen behind you.
Okay, so we're gonna go ahead and start.
Did it go? No? Yeah, it's still going.
Yep, so, okay. Now we really got it. So all she's seeing right now, and for you guys couldn't see it, just a blank screen. So she has her eyes open, just feet together. This is kind of condition number 1. We're gonna do 20 seconds.
Almost done.
Okay. Okay, so she completed trial 1. So yeah, go ahead and proceed. So, and the next one's gonna be when it tells her, she's gonna close her eyes. So just kind of like you guys did as you were standing there. So eyes are closed, we're going for 20 seconds. Again, the headset's measuring sway, so you can see a little bit of that movement. Almost there. Okay, so that's complete. You can open your eyes. Okay, so this one, she's going to keep her eyes open, but the headset itself is actually going to kind of play a trick on her. So when she does move, the headset's actually going to look like your vision is locked. So it's going to kind of give your brain some false information.
Shit. Oh, can I close my eyes?
Try to keep them open. We won't let you fall. Promise.
Holy moly. Oh, that's your thingy.
Yeah, no cheating. You're almost there. You got 4 seconds.
Oh, wow. Okay.
Okay.
See, it got real fun.
Yeah. So the only thing that changed is what she saw from her eyes.
Whoa.
So a lot of times what that tells me, because we get input from different things, is she is heavily reliant on her vision. So she probably doesn't use as much of her vestibular system or what she feels from her feet. Okay. There is another test. We are actually going to skip this one because if that was that hard, I am not
I was just going to ask you that. I'm like, we're not doing that,
the
are
next
we?
one, actually, what would happen is what she would see. It would look like her spaceship was spinning.
Oh.
It is significantly harder. We do not necessarily do it on everybody. If she did that and that looked pretty easy, then I would say, okay, yeah, I'm going to do that because it's going to give me a little bit more information. But because she already had a challenge with that, we're going to skip past that one.
Thanks.
Now we're going to do 3 more conditions. So eyes open, eyes closed, and then where it plays a trick on you. But we're going to do it standing on a softer surface.
So hit skip. On this one.
Yep. And then just pause. Actually, if you reach out, go ahead and do that. You can hold it. I'll let you hold it now. So if you want to grab that piece of foam. I'll tell you what, we're going to actually make it so you can see.
Oh, good.
Okay.
All right.
Yes, so you're going to stand on there.
Come back just a tad.
Yep.
So, and when we're doing this, we can actually make it so you can see through the headset. Well, it's kind of a grayscale, but okay, I'm going to tap it. Okay, did it go back to your spaceship?
Oh, yes.
Okay. All right, I'm going to back up so you can't cheat anymore.
I have.
Jennifer,
Trust me, you're going to be fine.
Okay, so again, this one's just going to go back to eyes open. Difference being she's now standing on foam. I'm going to kind of skip past the instructions for you. Okay, again, 20 seconds, eyes open. Okay, she's completed that one. Okay, and this one's going to be the same thing one more time, eyes closed. Okay, and then when it counts down, you'll just close on 3. So what you're going to see, so when she had her eyes closed and she was on solid ground, she stayed fairly still. So you can see how much of a difference that makes.
You're good. You're good.
I know. Thank you for being there.
Yeah.
Be on my butt.
Trust.
It is. This is worse than that one where you have to trust.
All right, so you got through that one.
Okay.
Got one more. You got it in you?
Sure.
Okay, good.
I'm always willing.
Okay, I appreciate that. Okay, this is going to be the one that she was pretty wobbly on solid ground, so.
Oh, my.
Almost there. Yeah, 4 seconds.
Couldn't quite do it.
Okay.
I was staring at a star.
Okay. The good news is you got through it. So I'm going to take this off your head. And thank you for demonstrating that. You did perfect. You can now see normal.
Welcome back.
Thank
Yeah.
you.
Yep, you're
Yes.
good. Okay.
Okay, and then we're going to skip it because it would have done that last one with the spin. So.
Never volunteer.
Okay. So again, going back to what I was talking about in terms of what I can see from someone, it's very subjective. I would say, yep, she had a lot more sway, she lost her balance, I had to catch her within however many seconds. This is actually going to create a report. So what it's looking at, I'm going to scroll down just so you guys can see the top a little bit. So the very first thing that's going to tell you is what your fall risk category is. So in your case, you were at a high risk.
Yeah.
Yes, exactly. That's good. Exactly. So in terms of kind of the very first thing, when you had your eyes open, solid ground, where you're at, you're in the 94 percentile, which is not bad. So as you can kind of come to see down, so where it drops down to those two red ones, so you can see you're at 68% for your vestibular system, and you're at 37% for sensory weighting preference. So remember how I said you probably rely a lot on your vision? So that's what that's telling me. So what happens is when something tells your brain something different from the other systems, your brain gets very confused, and that's why you end up losing your balance. So identifying what we actually need to work on. So in her case, if she's really reliant on her vision, we actually have to train the other two systems. Because if you're in an environment where you have your eyes closed or it's dark, you're going to be very challenged. And so when we're working on, and again, we're going to go talk about peripheral neuropathy, how do we restore some of the sensation from feet? That's going to help restore some of that. And if I'm working on vestibular rehab, there's ways where we can retrain or recalibrate that system to allow it to tell the brain a little bit more accurate information so that it can rely on it. So that's kind of what it imprints. And then when we do is we'll go through to balance exercises, work on these things, and then we would re-administer this test. And my hope would be at that point that your scores are going to have increased. But this allows us to basically create an idea. It's not, I didn't make it up. Basically, those sensors did, and so it's a more objective way. And a lot of times when we're working with insurance companies, when they say, okay, is PT justified? We have to show that we're making a difference. I can say we are, but again, that's me saying that, whereas this is actually going to be a value. So when we also use the VR headset, it's not only an assessment tool, but it also has different games that are integrated into it that you actually play wearing the headset that work on retraining these things. So we're not going to talk a lot about that, but if you guys are interested, you can certainly ask questions at the end, and I can kind of go a little bit more into that too. So, okay. Okay, and this kind of just recaps what I was already said. So what that VR assessment does. So it's going to allow us to objectify where you're at. It's going to help us to specifically identify where your deficits are so that we can focus. And it's going to allow us to also monitor and track your progress. So we're going to be able to show improvement. So, and again, kind of what that score showed us. So this is just a recap, has a vestibular score, how well that system's working, visual dependency, how much you rely on your eyesight, as well as somatosensation score. So if someone had a somatosensation score that was really low, it would tell me they don't get a lot of input from their feet. And that's where some of the peripheral neuropathy stuff will be helpful. Okay, so again, recap, what is vestibular balance rehab? We're working on identifying where your challenges are, identifying things and working specifically to help improve those. Integration of static and dynamic components. So this is one other thing that is important to realize. So a lot of times, again, I'll say, okay, people are working on balance at home. What are they doing? I'm standing on one foot at the counter. I'm trying to balance on one leg. That's great, but that's static balance. So that really doesn't have, I mean, it does have some carryover into day-to-day life, but we do a lot more functional things. So it's the person that says, I like to go hiking. Well, you can probably stand on one leg all day, and that may or may not help for that. So we try to integrate in a little bit more activity-based balance types of things, which are going to have a lot more carryover in those types of things. And kind of my ultimate goal in terms of when I'm working with someone is basically helping people to move confidently and to live full. So again, you want to be able to do the things that you enjoy in life and not want to do them because of your balance. So, okay, I think that is the end of my portion.
Okay. Do you want a chair so you can sit?
I'll be okay.
I'm going to steal
yeah.
that. I'm going to let him sit. I'm like, too bad. I'm assigning you a chair.
Okay,
Changing of the guard. Okay. All right. Let's see this. Okay, doc. All right. So, what is peripheral neuropathy? How many in here know they have peripheral neuropathy? Just a show of hands. Okay. All right. So, those of you who didn't raise your hands, you may have heard of it, but it's basically a condition that results from damage to the nerves outside the brain and spinal cord. And there's different kinds of nerves. So there's the sensory nerves that we were just talking about when you feel the ground. So the feeling of touch, temperature, vibration, pain. And when these are damaged, you can feel things like numbness, tingling, burning, or shooting pain. Some people feel like they're walking on broken glass. Some people describe it as walking on sand. So that's kind of the sensory nerves. The motor nerves can also be involved. So that's like controlling the muscle movement. So if you have peripheral neuropathy, you could have weakness as well down in your ankle. So that ankle strategy for balance becomes affected if you are a tripper, if you keep tripping over your toes or walking up the stairs. The autonomic nerves are sometimes involved too with peripheral neuropathy. So blood pressure, digestion, sweating, damage can cause dizziness upon standing, digestive issues, just temperature dysregulation. So that's kind of all the nerves that could be involved, right? How many people live with peripheral neuropathy is what this slide is. It's quite a bit, actually. I think the part that really got me is that there's 100+ known causes. Yet most of the people I work with don't know what is causing their neuropathy. Some of them, if they're diabetics, we kind of know that there's a diabetic neuropathy. So 60 to 70% of diabetics have it. And 30%, it's idiopathic, where we just go, we don't know the cause. And 20 million Americans are affected with it. So quite a bit. So those of us that are 55 and older, which I think is a lot of people in this crowd, it's an estimated 8% of that population is affected. So it's pretty, I'd say there's a lot of people that are frustrated with it because there's not a lot of options, right? So here's my slide on the frustrating landscape of traditional treatment. So there's gabapentin, so basically medications to try to manage the nerve symptoms, antidepressants, topical treatments, pain medication. So pretty much the bottom line, there just really isn't a lot of options for neuropathy. So that enters in what I want to talk about that we have called StimPod, and it's pulsed radio frequency. And pulsed radio frequency has been around for a while. Have any of you heard of the nerve ablation procedures that they do in the spine for low back pain, for example? Yeah, so that is radio frequency that they're using. It's just constant radio frequency. So that's going to ablate or cauterize the nerve, damage it, right? They're trying to make that pain go away. This is using pulsed radio frequency. So it's not going to damage the nerve. It's not going to cauterize it because it's a pulsed way of delivering it. It basically resets the nerve. So it stimulates nerve repair and regeneration. It's been around. If you talk to physiatrists, which are MDs that specialize in pain management, they are very familiar with pulse radio frequency. It's often used in the surgical suite, right? So the patient is under anesthesia and they can penetrate the skin and they'll put that pulse radio frequency right at that nerve where it needs it, and it's a one-time treatment and it's resolved. So obviously what I have in our clinic here is a unit. We're not putting you under anesthesia. We're not penetrating the skin with it. It's a probe with some gel, and it takes a couple months of sessions to get the nerve to be reset. So a little bit different, but same technology. It does bring down inflammation around the nerve as well. But usually almost everybody with using StimPod will notice something different even in the first session, where they might just feel a portion of their foot, like the carpet again, where they couldn't feel it before, or if it's their hand and they couldn't feel texture, they'll kind of run their hand on the wall and be like, I can feel the wall, where they couldn't beforehand. So it's pretty remarkable. Some people make a full recovery with using StimPod, and some people feel like they get about 30% better. That's the part that we can't always tell you. How much will it work for you in your case? If you're a diabetic, you definitely have to have your blood glucose monitored, and that you're doing a good job of keeping your blood glucose in control, because nerves don't like their glucose to be too high. So that is something that we would just have to talk about with you if that's your situation. So what to expect if you had a treatment? It basically is 5 minutes per nerve, and in the leg, since we're talking about peripheral neuropathy, there's basically 2 nerves that we're going to hit, so it's 10 minutes per leg. And it's pretty painless. I'd say some people say it's uncomfortable. It's not their favorite, but it's certainly not like a pain, like a nerve conduction test. Has anybody had that done? That's awful. So it's not like that. I get asked that. And there's no downtime. Once it's done, it's done. It doesn't hurt or linger. So resume normal activities. There's no systemic effects like medications. The other things we use for neuropathy that can be helpful too, red light therapy. PEMF is pulsed electromagnetic field therapy, so that is also helpful, and EMTT. So I don't think I said this in the previous slide on the stim pod, but that pulsed radio frequency does cause an electromagnetic field. And then you'll see here on this slide, these two other things, PEMF and EMTT, are also magnetic fields. So it's kind of interesting that with the nerve stuff, that is how it responds, the cellular response to that. It basically kind of restores the cell voltage. It opens up ion channels. Things can communicate again. I'm not going to go too far in the weeds or I'm going to put you all to sleep. But what we are seeing is pain is reduced. We are seeing people get their sensation back. One gal described it as she used to feel like she was walking on broken glass, and now she feels like she walks on cotton. I'll take that all day, every day. Better sleep. A lot of times people with neuropathy don't sleep well. And then better balance. We kind of just went over, you get a lot of your balance, your input from feeling the ground. So if you can start to feel the ground again, your balance reaction is going to be better in that department. I think one take home that I hope everybody leaves with is that balance can be retrained, that we want to give you hope for that. It's not fixed, and the brain possesses a capacity to adapt and reorganize. And this is just some of the statistics when you work on vestibular stuff, how much better your balance can be and you're less likely to fall. So, you know, BPPV, the resolution rate is 80%. When you work on gait and balance, you improve it by 25%. So this is kind of what that slide is just trying to take home, is just give you hope that if you work on these things, the brain and the body is able to adapt and improve. So I'm going to segue off of that a little bit, just the neuroplasticity of the brain. We do have one other modality newer to our clinic, is hyperbaric oxygen therapy. Has anybody heard of that before? A few people? Okay, so what it is you're breathing oxygen through a mask at pretty much like 95%, and then the chamber increases in pressure, and that pressure causes more oxygen into the plasma. So like up to like a 400% increase in oxygen being delivered to your tissues. So what we're finding in terms of literature is that can be really helpful even with a stroke or a concussion or a vestibular hypofunction. So even some years later, some of the research that's emerging is showing that using hyperbaric oxygen therapy helps those cells recover that were once kind of dormant in the brain. So now this is kind of what that slide is about, that balance trouble after stroke, TBI, vestibular problem, it's not just the spot that got, quote, hurt or injured in that insult, but even the tissue around that is kind of just firing on low capacity. And so if we can get more oxygen and blood flow to it, it kind of reawakens. So flood that with oxygen and blood flow is kind of the message there. And there are a couple studies that I highlight on these slides that have been done even 6 to 36 months after a stroke that did hyperbaric oxygen. And it did show on the scans, even the area of the brain that wasn't working, and then how it did work better. And then the cognitive testing that these patients felt just more alert, better cognitive function, better balance. Same with this other study that's up on the slide with concussions. Some of these people are 1 to 5 years out after their concussion and still not feeling normal and went through hyperbaric treatments. Hyperbaric for this kind of stuff is usually several months long. So it's kind of it's a commitment. But so that research is emerging. And I do think it has a place. And if it's something that you've struggled with, it's something to consider. So this slide, just who belongs in the chamber, maybe balance changers after a stroke. that you've reached a plateau perhaps with traditional PT, lingering symptoms after a TBI or a concussion, a vestibular hypofunction, maybe an inner ear loss situation, and you just want to see if there's another thing that could get you further. Just feeling less steady, just kind of that brain fatigue, brain fog type of thing. So happy to talk about that more if somebody is interested. So I'm going to wrap up. We'll have time for questions as well. The form that you've got, if you have that handy, I'm just going to kind of go through where hopefully you find yourself to help you moving forward after today. So if you were at risk for falls, if you've had a fall, or when we were doing the balance test earlier, if you're at a risk for fall or you're afraid of falling, you've had a fall, you have dizziness, really the next best recommendation is going to be schedule a physical therapy evaluation so we can get to the bottom of what is truly causing it. We can use the VR assessment to really hone in, just like we did with our wonderful volunteer earlier, and get a really definitive plan for you. Another option could be that you're not really having issues, but you want to stay proactive. So that would be possibly just booking that VR assessment just to know, how does my vision, my sensation, and my vestibular system work? Are they working well? Do I need to be doing something different to just stay active and independent? So prevention stuff is often not covered by insurance. So that step, we couldn't do that in that case unless you had some reason for like having falls would qualify. And then the other one, if you have peripheral neuropathy, again, I would schedule the PT evaluation, and then we can book a free trial with our stim pod and see how you react to that. And then if you've had a previous stroke or a traumatic brain injury or concussion, and you're still having cognitive or balance issues, and you'd like to have an evaluation and discuss if the hyperbaric would be an option for you. So that's kind of the 4 categories I kind of broke things out into. Happy for both of us to take some questions, and that is it for tonight. If you fill out the form and you want a copy of my book, I have that. So if you want to bring your form up, I do have a couple of my book is Forever Young, You Can Age Gracefully. So it has a topic, like it breaks it into like low back, knee, all the different topics from head to toe, basically. So if you'd like that, happy to give you a copy. But for now, let's just take questions. You just stand there. Yeah, I'll go back. Go ahead.
How would having a spinal cord stimulator take those tests therapy?
Right. Yeah, an implanted electrical device, we couldn't do the stim pod or the electromagnetic stuff, the EMTT, EMF, but hyperbaric, we would just call the manufacturer to see if your device would be compatible. Most of the time with the mild pressure chambers like ours, you can. So like pacemakers can go in the 1.4 pressure chamber that we have. We would just want to call the manufacturer and get clearance on that. Yeah, good question. The question was if you have like an electrical implanted device, like a stimulator, a spinal cord stimulator. So a pacemaker, spinal cord stimulator, any kind of electrical implant, then some of those modalities can't be used.
So my neuropathy is related to going to chemo, and it's been about a year since I finished, and so I've been like thinking it's going to go away, but maybe it never will. But I've had other related issues as a result of that. I don't know, like I got out of the blue, I got plantar fasciitis, so I don't know. Anyway, the point is that I'm wearing hokas now, and I'm wondering if I'm making it worse by having such a huge cushion between my foot and the floor or ground.
You're having to work harder. Like when we put people on foam, there's more, so there's a little more effort.
Correct. There you go. See if mine works. So yeah, Hoka's in terms of comfort are a great shoe, but yeah. Okay, yep. So she was inquiring about, so she wears Hoka shoes, which are a softer cushioned shoe. kind of carry over in terms of what does that do for your balance. So answer being that yes, they feel good. There is a lot of cushion on your feet, but unfortunately for balance, they actually are not the best because it is very similar to standing on that foam. You're not allowing your body to get that proprioceptive input. Yeah. So actually a more firm shoe does tend to be more helpful. Yeah.
I'm going to just piggyback on that. So on the chemotherapy, peripheral neuropathy, we have been treating people with that as a cause of the neuropathy. And one gal, she's a friend of mine, she had peripheral neuropathy for 12 years after surviving cancer 3 times. And, you know, I told her, I'm like, I don't know if this will resolve it, but let's give it a shot. And she used it for about a month, the stim pod unit. And to this day, and that was over 2 years ago, fully recovered. So no more numbness, no more tingling. And she was a tripper. Like she had weakness with picking her foot up. She just thought she was going to be a tripper for the rest of life. But yeah, she doesn't trip anymore. She can walk more confidently. So it completely resolved it for her. And that was the cause. And then we've had other people with some chemotherapy induced peripheral neuropathy with improvements, but maybe not 100% resolution. So that's what I mean about some of this. I can tell you it works, but sometimes I don't always know what percentage. Yeah, but a lot of people are like, well, I'll take anything. So, yeah. Any other question? He has a mic for anybody who has another question. So that way we can. Any other questions?
I've had cerebellar atrophy for a number of years, and I've been struggling with vertigo for many, many years. And I had my peripheral neuropathy for about 20 years. And I did go to a functional chiropractic neurologist, and he helped a little bit, but it was so difficult. I've had enough falls that I have retinal occlusion and macular edema. I'm wondering how all these play in and if anything can be done for any of those.
Yep. So I will say that in terms of when we're doing our assessments for vestibular, we're looking to identify 2 different things. So we look, is it a peripheral problem? Meaning, does it occur from basically the brain outward, or is it a central problem? So with atrophy, that would be more of a central problem. So I wouldn't say that things that I would have you do is going to take away all of your vertigo symptoms. However, with that being said, I think working on balance can minimize your risk of falling. So central things, when they do occur within the brain, and this is going to be some of the stuff people will have residual dizziness, vertigo things from having a stroke, which again is going to be a central problem. Some of the techniques that we're using for peripheral issues aren't going to be quite as effective for those, but the balance portion of it in terms of working still on, again, sensation from your feet. We can retrain your vestibular system, working on pulling in more visual cues can help with minimizing the fall risk. So, and obviously if that's one of the larger problems from it, we want to try to keep those to a minimum.
And if you do have peripheral neuropathy, then doing the stim pod would be helpful. So I see your case as a PT case in terms of like trying to decrease your risk of fall of all the compensation things that he was just talking about. And then the stim pod for peripheral neuropathy. And then the hyperbaric oxygen chamber would be another thing to just try to see what impact that would have on the brain and the cerebellum and getting more blood flow and oxygen to those tissues.
I was just wondering about insurance with those things. Because we all rely on insurance so much. I was wondering, how that works with it.
Yeah, insurance doesn't really want to cover a lot of these advanced technologies. So I wish it did, but it doesn't. Yeah. Yeah. I mean, it does. A lot of it doesn't even over in Europe. I mean, they're paying cash as well for like using EMTT and shockwave. But I think the more data that comes out and more research, I think eventually that tide might turn a little bit. But I'm also kind of to the point where they just seem to want to pay less and less every year, right? So, yeah, it is. But at the same time, I mean, you want to feel better? We've got options. Yeah, I just see my role as like letting you guys know what's available and let you guys make decisions from there. Yeah, and we do give free trials for people, and we've got packages that really make it almost like you're getting, if you buy one full package, almost other things become like 50% off or more. So we try to really make it workable for you. So. Anybody else? Oh, you got one behind you. Tingling in your feet?
Yes, and I think when we read the article about.
Yeah, so the tingling in the feet is the neuropathy, more than likely. That was sort of my portion that I touched on. You can get tingling in the feet from a nerve being pinched in the leg, too. So it's a matter of figuring out where is that nerve being compromised. Is it truly peripheral neuropathy, or is it, a pinched nerve from your back that's causing tingling all the way into your feet? So we'd have, again, it would be more of like an evaluation and then figure out what is the cause of that tingling. And then if the cause is truly from peripheral neuropathy, StimPod would be, the pulsed radio frequency would be very helpful. If it's a pinched nerve in your back, we often do EMTT at the spinal level to decrease that inflammation where the nerve's being pinched, and then do StimPod to the nerve as well to speed things along. So, yeah. Any other questions? Okay. All right. Well, thanks for coming. I hope that was really informative for you guys. Turn in your forms if you would like a copy of my book. I know, Noel, did you bring those over here? Okay. Like, where were they?
I think they're at the front.
Oh, they're up front.